Good morning. My name is Dr. Celia Rod, and I'd like to start off the rounds. And I'm going to be speaking first, but I'm going to be introducing Dr. Socorro, who's the second speaker. Dr. Socorro did his undergraduate degree in biochemistry and zoology at the Egerton University in Kenya and his PhD in toxicology at the University of Saskatchewan. Following this, his PhD, he enrolled in a postdoctoral training in clinical biochemistry here at the University of Manitoba. He's currently a clinical biochemist with the Diagnostic Services of Manitoba, based here at the Health Sciences Center, and is also the program director of the postdoctoral training program here at the university.
Good morning. I'll be speaking second following Dr. Celia Rod, but it's a pleasure to introduce Dr. Celia Rod to the audience today before she starts talking. Dr. Rod is an associate professor in the Department of Pediatrics and Child Health at the University of Manitoba and at the Children's Hospital. She undertook her medical degree at the University of Toronto and also did a pediatric residency at McGill University, following which she enrolled in endocrinology fellowship programs at the Universities of Toronto and University of Minnesota in Minnesota. In 2010, she completed a master's degree in epidemiology at the London School of Hygiene and Tropical Medicine in London, United Kingdom. Up until 2013, Dr. Celia Rod worked at McGill University and McGill University Hospital as a clinical scientist and was the program director for the pediatric endocrinology program at McGill University for the 15 years following that. Her research interests are in vitamin D, mineral homeostasis, pediatric laboratory reference intervals, pediatric bone health, and epidemiology. She has published over 70 peer-reviewed manuscripts in journals such as CMAJ, JAMA, and Journal of Clinical Investigation, and is currently funded by CIHR and eRare. It's a pleasure to team up today with Dr. Celia Rod on this important initiative, and we hope to be able to provide you with the facts and details of what the status of vitamin D is with a clinical context in Manitoba in particular. With that, I would like to invite Dr. Rod to start our talk.
Thank you. Thank you, Abdi. Thank you. We're just presenting our conflict of interest. My membership on the advisory board has no bearing on this talk. So we have a couple of objectives that we hope to cover in about 45 minutes and then entertain your questions. We want to quickly review vitamin D biochemistry. Can't have a talk about vitamin D without doing this. We want to discuss what are the recommended intakes for vitamin D and the various sources that have put forward these recommendations. Also want to talk about how frequently 25-hydroxyvitamin D is tested and looking at trends and implications, and particularly look at Manitoba experience. And then finally, review methods to ensure that across the population that their vitamin D status is adequate. So as you open up your various newspapers, those high-impact journals that you read on a daily basis, you're going to see vitamin D proudly displayed across this. And it's not only in the media, but it's also in the general science literature as well, too. When you look at the Globe and Mail and other papers, we talk about vitamin D fighting Crohn's disease, heart disease, preventing cancer, slashing the risk of MS. Could this really be true? Well, let's look at the number of manuscripts published annually on vitamin D from 1922 to 2014. And you can see that we're now up to about 4,000 manuscripts annually that are published. And there was a very exponential rise here over the last 15 years in terms of the number of papers published. And part of the whole interest stems when you look at this composite slide. I'm just going to describe, on the x-axis, you have median 25-OHD concentration. You see this gold bar here at 75 nanomolars. And you look at relative risk down one y-axis. This is BMD here, and this is another measurement on your second y-axis. So the bone mineral density increases, and you can see that once you reach that golden bar of 75, you're going to have fabulous bones. When you look at both the fracture relative risk and the colon cancer relative risk, again, as you traverse this line, you're seeing a statistically significant reduction in colon cancer and fracture risks. And the same thing when you're looking at musculoskeletal outcomes. But I need to caution you, correlation does not always equal causation. These studies that are presented here are largely observational, but they have really piqued our interest. You then look also recently in the Globe and Mail and the Calgary Herald, starting in January, there were these outrageous advertisements that were published on the third page, large, and it said, quite frankly, there was a big vitamin D mistake. The IOM, or the Institute of Medicine, got it wrong. We should be taking 7,000 international units instead of 600. They said it was a mathematical error. So just to pique your interest on those, I'm now going to talk a little bit about biochemistry. So we like to refer about vitamin D, or vitamin D3, as the sunshine vitamin. We know it's made in our skin, and it's also made naturally in the skin of other animals and oils in the fur. It is not in itself a hormone, because we're talking about cholecalciferol, that's vitamin D3, and it's not typically found in fruits or vegetables. So where do we normally find vitamin D? Well, there are not a lot of foods that are naturally enriched in vitamin D. So you may want to eat a lot of egg yolks every day to get your vitamin D. I think probably not. Fatty marine fishes such as salmon and char, mackerel are fairly rich. So is seal blubber, other things that we don't necessarily always eat, but indigenous populations do. Interestingly, farm salmon has about a quarter of the 25-OHD compared to wild salmon. And so in the 1970s, Canada looked at the degree of rickets and osteomalacia, or vitamin D deficiency, that we had, and actually instituted, and we're one of the few countries in the world that actually do fortify our food. So milk is fortified. For every 1 glass that you drink, you're getting 100 international units. Margarine, every 4 teaspoons, equivalent amount of vitamin D, and some yogurts are fortified. But again, for us, the major source of our vitamin D is through the sun. But as a very good pediatrician, these children are wearing an SPF of 60, so they're not making any vitamin D right now. So besides food, and again, you have to choose fairly correctly in terms of the foods that you're going to be getting for your source of vitamin D, we know that we will rely on the sun. In sunny southern Manitoba, you can only make vitamin D from April 1st till October 1st, based on fairly sketchy studies from the 1970s. And if you go further north, you're not going to make it. So over this glorious Easter weekend, probably some of you are out there making a little bit of vitamin D. If you wear sunscreen, that you will then abrogate your vitamin D synthesis. And people who have darker skin than I do will certainly take longer to make that vitamin D with that cutaneous exposure. So many of us then rely on supplements. And there are many, many products, and I refer to both D3 and D2, or cholecalciferol, the mammalian form, and ergocalciferol is actually a fungal form. D2 is often the injectable form that we have, and also some of our highest dose products are D2, and we'll come back to that particular point when we're actually talking about measuring the status of vitamin D. So I've already mentioned, we know that the UVB light is very important, that we can make then vitamin D3 in our body. There is an enzymatic process in the liver that converts everything to 25-hydroxyvitamin D. And this is non-enzymatically, so everything that you have either through sun or supplements will be converted all to 25-OHD, and it's not regulated. Then the kidney does its exquisite regulation in terms of just making the synthesis of 1,25-dihydroxyvitamin D, which is actually a hormone. So this is the same schema or pathway. We have vitamin D through our sun pathway, or if either taking your supplements or your vitamin D enriched milk that I know you're all drinking, comes through the liver to make 25-hydroxyvitamin D. And then under the influence of parathyroid hormone, phosphate serum concentrations, as well as other hormones like FGF23, you're going to make 1,25-dihydroxyvitamin D. This is in picomolar quantity, so 1/1000th of your 25-OHD concentration. So it's a very potent hormone. And we know, looking classically, just to stretch your brains a little bit more in the endocrine direction, that as we drop our serum calcium levels, the first mechanism in terms of maintaining serum calciums in the normal range is your parathyroid hormone. It's going to turn up very quickly and then actually cause the plasma 125 to increase, then causing a whole cascade of bone reabsorption, calcium, gut, and intestinal reabsorption to maintain normal serum calcium for both musculature and for cardiac function, as well as elsewhere in the body. In this very busy slide, I'm just going to draw your attention to the fact that we know that 25-hydroxyvitamin D is synthesized from the foods and supplements, goes to the kidney, and it can be made into 125 and used through a whole series of organs in our body. But when we're not needing to synthesize 125, we're going to shuffle it off to a more water-soluble degradation product called 25-dihydroxyvitamin D. But really, to draw you to this nice pink circle here is that individuals also need to have 25-hydroxyvitamin D because there is not only renal synthesis of 125, but many, many tissues will make their own specific 125, such as the skin, immune cells. So in renal dysfunction, we thought previously we needed to just give 125, but we know that we also need to provide the substrate to make local 125. So as alluded to, we know that vitamin D works on the bone, and it works on many, many other tissues. When there are very low levels of vitamin D, we have a proximal myopathy, so you can have muscle weakness. Vitamin D is important for insulin secretion, normal contractility, calcium concentrations, which are also important in terms of the musculature, cardiac, and skeletal. But coming to the big question, and I used to call it the $64 million question, but I think it's actually the $64 billion question, looking at our healthcare costs and what we're doing with vitamin D testing, is how much do we need? And there are several schools of thought, and I'm going to present one of them. And I'm going to rely on the information generated from the Institute of Medicine's report in 2010. The Institute of Medicine was established in 1970 to examine policy matters pertaining to the health of population, establishing how much folic acid was required, how much vitamin D, how much calcium. So grappling very large questions and having expert panels decide this. So the first report that they had about calcium and vitamin D was in 1997, and this was updated in 2010. The Canadian government is involved in this Institute of Medicine report. It recently paid a third of the cost for this most recent report. And there are two Canadian experts, Dr. Chris Kovacs, who's an endocrinologist in Newfoundland, and Dr. Glenville Jones, who's a biochemist in Queens. Largely, their data was examining the multitude of manuscripts that were out there, and particularly paying attention to two Agency for Healthcare Research and Quality reports. One came out of Ottawa and one came out of Tufts. And their goal was to generate dietary reference intakes, or actually to update them. And this is their summary page. If you go to the web, you can actually have a look at it. So we're going to quickly look down this because you're going to see this slide a number of times. So for the dietary reference intakes, it actually talks about 4 different categories. It talks about estimated average requirements, recommended dietary allowance, and upper level intake. And for most of you sitting in this audience, you're probably needing a total every day of between 400 and 600 international units, and that's both from food and supplements and sun. So this was actually an increase in 1997 that they had actually just recommended 200 international units. Health Canada has adopted these particular suggestions put forward by the Institute of Medicine. I mentioned already that there is something called the EAR, or the Estimated Average Requirement. And this is the intake that meets the needs of approximately 50% of a healthy population. An RDA, or a recommended daily allowance, meets the needs of approximately 97% of a healthy population. But this is not actually a target that's intended to be met by all. As a healthy population, we're supposed to be as a healthy individual and a healthy population, you're supposed to be somewhere in between these two. So between 400 and 600 international units per day. The third level that I mentioned previously was the upper level intake, and that's the highest intake level that can be tolerated without adverse events, such as hypercalcemia, hypercalciuria, kidney stones. And when there's insufficient data, an adequate intake, or an AI, is actually provided, and that's just an estimate. And that's particularly for my age group in the infants in the 0 to 1 years of age. So this is Health Canada's website. And you know that they're just actually providing here just the RDA, which is the intake that's required to meet approximately 97.5% of a healthy population. So how did the Institute of Medicine actually come up with these recommendations? Clearly, the Calgary Herald and the Globe and Mail had a better reason in terms of saying, well, you just multiply what the Institute of Medicine said and bingo, you've got the right answer. So the Institute of Medicine actually looked at many, many, many health outcomes. They looked at cancer prevention, diabetes mellitus, musculature, fractures, preeclampsia, you name it. They looked at it. It's over 1,100 pages. Looked at all of these outcomes, but the only outcome or health indicator that they felt that there was enough valid information was actually bone health. And what they're looking at specifically was looking at 25-hydroxyvitamin D concentrations, because that's a marker for them in terms of how well are we absolutely absorbing calcium and across the intestinal wall. They're looking at the relationship between 25-hydroxyvitamin D and parathyroid hormone. If you have low parathyroid hormone levels, your parathyroid hormone goes up. And when this is sufficient, this should actually reach a plateau, although it's a bit variable in terms of the kinds of relationships that we see. Looking at absolute bone mineral content, or BMD, looking at how much bone is actually mineralized when you do iliac crest bone biopsies, how many fractures that we have. And the evidence was considered best when the studies were done when there was low UVB radiation, so we're looking only at food and supplement intake, and of course this was matched with a good calcium intake too. So their recommendations, as I've already alluded to them, was that approximately half of the population needs to take about 400 international units in to attain a concentration of 25-hydroxyvitamin D of 40 nanomolars. Their RDA allowance indicates that 600 international units would generate a concentration of about 50 nanomolars. And I'll come back to those numbers, as will Dr. Socorro shortly. They actually state that the reasonable range for the desired 25-OHD is between 50 and 125. Deficiency is under 30, and rickets is probably under 27.5. So here again is that lovely panel that I showed you before. And I'm highlighting the calcium panel because calcium and vitamin D are inextricably intertwined. You need to have enough calcium for your vitamin D to work and maintain your normal serum calcium concentrations and maintain your bone mass as well too. Additionally, your vitamin D economy is optimized when you have enough calcium aboard. So when you have enough calcium in your diet, you're drawing on less of your 25-hydroxyvitamin D to be made into 125 to then pull more from your gut, as well as acting on your bones and on your kidneys. So again, a couple of statements from the Institute of Medicine. And I'll read this to you. The data currently suggests that the fractional intestinal calcium absorption reaches a maximum when you have a concentration between 30 and 50 nanomolars, both in children and adult. A value of 50 nanomolar allows for some uncertainty in the data and a buffer against seasonal or dietary variations in your intake of vitamin D3. They also say practically all persons are sufficient with a 25-OHD level of at least 50 nanomolars. Serum concentrations above 75 nanomolars are not consistently associated with increased benefit, and there may be concern with concentrations above 125 nanomolars. And as you can see, you get a little bit of a flavor of the talk, that the recommended intakes actually obviate the need for blood testing in the general population. I want to turn to the upper tolerable limit intake, because there's so much interest in vitamin D. And there's a lot of purchasing of vitamin D that's going on as well too. How much can you actually take and actually be safe? So the ULs are actually intakes that can be consumed for long periods of time and appear not to cause any harm. But unfortunately, these are based on very limited scientific data. So on the far right of the panel that I previously showed you, you can actually see that 4,000 IU is set as our upper limit intake on a daily basis. In case, as I said, the Calgary Herald and the Globe and Mail are correct, it's important to know that there was most recently another review of all of the published literature and zeroing down on important studies, that another AHRQ was published in November of 2014, and it completely reaffirmed what the Institute of Medicine has stated in 2010. Conclusions are that a lot of the publications are inconclusive, many are conflicting, and many are observational, limiting how we can actually look at effect. Some of them actually demonstrated U-shaped effects, such as an increased intake or an increased 25-OHD was actually associated with an increase in all-cause mortality or hypertension. And I'm just going to show you another study just to explain what I meant by a U-shape. So this is the report in the Journal of Bone and Mineral Metabolism in September of 2014. It's called the CHAMP study. It's a cohort of Australian elderly gentlemen, that's over 70, and looking at their fracture risk. And these were largely men that did not take supplements. So you can look here on the y-axis. These are the number of fractures that the gentleman had, and looking at the quintiles for their 25-OHD concentrations. These are gentlemen who had low levels, less than 36 nanomoles, and you can look at the number of fractures that they have. This is the referent population here between concentrations of around 60 to 72 nanomolars, and you can see the gentleman that had higher concentrations had probably very similar, and they're statistically the similar number of fractures as though with low concentrations. At this point, I'm turning over the mic to Dr. Socorro.
Well, thank you very much, Dr. Celia Rod. I hope by now you have a flavor of all the controversies and the facts as related to literature with recommendations on what would be an optimal vitamin D level. Most consensus laboratory values recommend a value of 75 based on, again, studies that showed that 75 might be beneficial as an optimum level, albeit there being no consistent evidence to suggest that levels over 75 might be beneficial. However, despite that, the Endocrine Society and the U.S. Preventative Task Force, as well as other guidelines, do recommend a 75 as a cutoff for vitamin D. What I would like to emphasize here is that an individual's skin color is as important as it is the exposure time to sunlight to initiate the vitamin D requirements that are met within a day. Individuals that are dark skinned require over 3 times longer time to be exposed to minimally meet the same amount of vitamin D synthesized in their skin as individuals that are fair-skinned or white. Most of the evidence that is generated with 75 nanomolar is based on individuals that are not taking supplements and observational studies that were done in sunlight-abundant regions of the world, and it has been noticed that individuals that are working, whether it's indoors or outdoors, easily attain a mean level of 80 nanomoles per liter, as evidenced by these studies that were done. Based on that, and also based on the fact that individuals as closely related to primates can easily attain levels of over 80 nanomoles per liter. However, in North America, individuals without supplementations do attain levels of over 40 nanomoles. And the question is this normal? If you look at individuals that take supplements of 1,000 international units a day, living in North American climates, their levels are possible to achieve about 70 to 75 nanomoles per day. If you move to northern remote communities, with 4,000 international units per liter per day, it is possible again to achieve. The fundamental question is, these levels confer any further benefit to the levels that are considered normal in individuals without supplementation, just taking the normal fortified diet in North Americans? And this is where the controversies are between the schools of thought. Nevertheless, in January this year, 2005, the U.S. Preventative Task Force published a publication in which they went back and reviewed the entire literature available on vitamin D. And they had some key questions that they were looking for to answer within this literature review. And one of them I'll just highlight here is the question, is there direct evidence that screening, and here screening is in context of population screening, for vitamin deficiency results in any improved health outcome? And it's surprising to note that there were 0 studies in that, and therefore none of the questions were able to be answered. They further looked at to see, are there any differences in screening efficacy between patient subgroups? And again, there were no studies that actually looked at that primary question, and hence any conclusive evidence of whether there's any benefit or not. The other question that they could not find any studies in was, what are the harms of screening? For example, for risks of procedures, false positives and false negatives in laboratory results, as benign as they might seem, there are some risks involved, and nobody seems to have addressed that key question, which is also very important in addressing some of these controversies that we have today. However, they did find, though, that about 17 studies could sufficiently answer whether the treatment for vitamin D deficiency using vitamin D leads to any improved health outcomes. And out of that, they found that there were some nested case control studies, and there were also some randomized control trials that were done that generated some fair evidence. But there were some limitations to that, and the limitations include studies. There were very few studies that looked at each outcome individually. Many studies reported few events, and some were underpowered because of the size of the population that they looked at. And the variability in the baseline for vitamin D doses was not standardized. And so the use of calcium co-supplements and the length of follow-up also was not standardized across these studies. However, it did generate some moderate consistency in the evidence that was generated. And the most important findings could be summarized as that vitamin D treatment was associated with a decreased risk for death. Vitamin D treatment was not associated with increased risk for falling, contrary to what people might think. Vitamin D treatment was not associated with decreased risk for fractures. And then there was very limited studies or data on the risk for cancer, type 2 diabetes, psychosocial and physical functioning, as well as disability, but generally no association with vitamin D treatment in these studies. So the question goes back to why there's so much confusion about what is the benefits of vitamin D in the context of population screening, and why is there so much controversy between what is an appropriate level of vitamin D. It's important to note, and this is also addressed within the U.S. Preventative Task Force publication in Annals of Internal Medicine this January, that part of the issue is all these studies are done on non-standardized laboratory testing. We all know lab tests are not created equally, in particular with vitamin D. What you're using to measure vitamin D matters as much as what you're picking up as what you measure. And this relates back to the methodological differences between the assays themselves. Partly not assays measure what you really think are measuring. So it's important to be able to know the characteristics of those assays before you can implement or understand the data that you generated or the data that you're looking at. So not all assays measure the D fraction of vitamin D2, which is the egocalciferol. And if they do, they don't measure them in equimolar concentrations as they do with other assays. And there's also the degradation product of vitamin D, which is the water-soluble fraction of which is 24-25 vitamin D, dihydroxyvitamin D. And this one can also cross-react with some assays as well, which can also influence the total results of vitamin D. So, in brief, because I won't go into the details of these assays, there are generally three broad classes of vitamin D assays, and some of them are quite old, and one of them are the competitive protein binding assays. The second one are the immunochemical assays, which are more frequent and more widespread nowadays, which employ antibodies that are raised against a specific epitope of vitamin D, and this is where the cross-reactivities can be quite varied based on the epitope of the antibody that is used within the assay, and it could cross-react with any other chemicals that closely resembles the nuclear structure of vitamin D. There's the more sophisticated chromatographic assays, which employ basically the separation, the ionic interaction of vitamin D moieties with specific functional groups within a column that separates the vitamin D, and then detected based on various different technologies, UV detection and mass spectrometry, which is actually the standard nowadays. So how do these assays compare? To just give you a flavor of the differences that are generated within these assays, which also contribute to the literature confusion as well. Using mass spectrometry, which is based on a charge-to-mass ratio, liquid chromatography separation, and then mass spectrometry as the gold standard, how do those assays compared to the mass spectrometry? And I will draw your attention to the circle here, which shows that the liquid chromatography using a UV detection correlates relatively well with the mass spectrometry assay. What does that mean? It means is if you have your true number as 100 nanomoles per liter with a mass spectrometry, the HPLC would detect anywhere between 82 nanomoles per liter to 120 nanomoles per liter. That is what you would expect to be given as a result from this particular assay. On the other hand, using the immunoassays, which employ antibodies raised against that particular moiety of vitamin D, depending on which assay you might be using, some cases you might not be better off than tossing a coin. So if your true normal result was 100 nanomoles per liter, any of these assays could give you between 37 nanomoles per liter to 175 nanomoles. The numbers that they generate might be somewhere down there. A good example, this being the worst case scenario. Now, does vitamin D2 or egocalciferol have an impact on the assays themselves? And the answer is yes. And this slide just best illustrates, and this is from a proficiency testing scheme, where they looked at the implications of different concentrations of vitamin D2 and how those correlate with the assays as indicated down here. And you would see that the higher the vitamin D2, some assays can give you quite a different bias in terms of the results that you receive. The mass spectrometry is not only consistent, but it's also precise to within less than 5% of the accuracy of the result itself. So this is an important information that has to be taken into context when these clinical trials are being actually interpreted and also analyzed, which I do believe does feed into what numbers are being generated. So does assay matter? I believe it does. But for general population screening, and such as the enhanced studies and the Canadian health measures, I think immunoassays are fine. But when you're dealing with particular individuals, and particularly individuals that are at high risk, I believe the assay does matter, and it's important to choose the right assay for that particular individual. And in this case, I might add that chromatographic assays are the best. We know the liquid chromatography mass spectrometry assays are relatively safely be called gold standard, and this is based on the fact that they meet their target values within 10% of the NIST standards. That means that the true value is being assayed. Because of this reason, there is tremendous interest that is generated with vitamin D, which is evidenced by the fact that there are patients pushing for vitamin D status, physicians wanting to know what their patients' vitamin D status are, but it doesn't always translate that a number that is generated will meet the clinical requirements of each patient. And again, within the context of asymptomatic, low-risk population screening. With that, I'm going to hand over to Dr. Rod.
Not only is there an increase in terms of the interest in all of these manuscripts, that society's impression has also changed too. And there's a very startling number of vitamin D sales that have actually happened in almost the last decade. So now vitamin D is the most popular vitamin that is actually sold in the pharmacy. So now this raises a question. Not only people are interested, they're taking vitamin D, but I think that there's also a demand in terms of, are people taking enough? And individuals are going to their physicians and asking that question. And I guess we're a little bit perplexed here, Abdi and I, because when you think about it, I don't have pediatric patients coming in and saying, well, what's my selenium or my manganese level? But perhaps I've spoken too soon, and that maybe this will be the next fad in terms of testing. So we know in terms of there is a huge increase in the number of volume of 25-hydroxyvitamin D testing. This was a recent report in Calgary. There was one published as well as a CBC report. And in 2010, we know that we did the math in Calgary, 1 out of every 6 to 7 resident was being tested for the 25-OHG concentration. When you look at the Manitoba trends, you look from 2006 all the way to 2015, you can then see that these are the number of tests done. There was a plateau in here as there was a change in assay. That this was originally 1 test for every 250 resident, and now we're up to 1 test for every 25 residents in the province. So it's a huge increase. When looking actually at the variability over that same time frame, that the blue represents those who are deficient, and you can see that that changes and probably has increased over that time frame, and the purple is actually those who have very high levels, which I think is actually a bit down close to 0, and that this is the trend for those over 75, and these are between 50 and 74. But you can actually see that there's a huge increase of the individuals that we're testing who are not actually clearly deficient by being in this blue zone here. When you actually look at the number of vitamin D tests per patient from 2012, 2013, and 2014, these are the total number of tests, and you can actually see the doubling here. You can see that there's been a doubling of those who've had only 1 test. There's been actually a doubling of those who've had 2 tests over that time frame, and that there are actually a number of individuals who are being tested greater than 10 times annually. I think then we've presented information in terms of what the Institute of Medicine has said. Well, this is what you actually need to require. If you looked at it and said, well, on the other hand, we're testing everybody and everybody's tests are generally pretty good. Well, really, what is our status in Canada? Do we really need to be worried? Should we be doing this amount of testing? Do we have high rates of deficiencies? And you'd certainly think that we might have high rates because we live in the north and we can't rely on our cutaneous synthesis year-round. And so we pulled out the data looking at some surveys that were done, the CCHS, which is the Canadian Community Health Survey, and the CHMS. CHMS is the Canadian Health Measures Survey. So in 2004, that there was a fairly in-depth nutritional review of Canadians, actually sampling what are they actually eating, and found out that they're taking in about 200 to 300 international units of vitamin D through foods. And that was, you can see, a decade ago. In 2007 to 2009, the health survey went around, or the health measures survey went around and actually obtained blood on about 5,000 Canadians over this 24-month period looking at the status. And this was measured by the liaison immunoassay. Military personnel and First Nations individuals were excluded from this survey. At that time, the survey participants, about 30 of them said that they took supplements in that month prior to that survey. And this was done throughout the whole calendar year. Interestingly, average 25-OHG was 67 nanomoles at that time, which is actually fairly robust for a Canadian population who lives fairly north. The differential between summer and winter was only 6 nanomolars. Often for many studies, we know that the summer is probably about 20 nanomolars higher, whether this is boosted by the supplement use or whether or not the Canadians they picked were pretty healthy, I'm not quite sure. When actually looking at those who are above 50 nanomolars, which is the Institute of Medicine says is an absolutely great number to achieve, so more than 74% were higher than 50 nanomolars, 81 if they took supplements, and about 60 said if they were not taking supplements. 87% were higher than 40 nanomolars, which is still actually pretty acceptable, and 94% were greater than 30. So very few were severely deficient. Of the extremes, so those who were actually very deficient, it was primarily people in winter time, which is not surprising because our cutaneous synthesis from the summertime does not last all the way to our nadir into February and March. And it was mostly the immigrants who are largely often darker skinned, often don't have the habit of taking dairy products, which is a very North American concept or European concept, and who may not also be in the habit of taking vitamin D supplements because they used to always make vitamin D when they were outside at home. At that time, only 40 individuals were over 150 nanomolars. So I think that we can be actually quite reassured that back in 2007 to 2009, the Canadian population, with only a third of them taking supplements, were actually doing pretty well. So This would actually then, if people were actually taking closer to 400 to 600 international units of vitamin D, I bet our Canadian standards would actually be even higher than that. And whether or not what's put forward by the Institute of Medicine saying that 400 international units will generate a 40 nanomolar concentration is probably a little bit conservative. You probably can do a little bit better than that. So I think moving forward that we need to look at the population and say Canada is doing pretty well, and that we need to move away from specific testing in generally healthy individuals, unless, of course, we're doing specific surveys or we have patients that we think are at risk, and I'll define that in a minute. We know what sufficient and safe intakes are. Those are anywhere from 400 to 4,000 international units per day. We can be pretty comfortable with that for the vast majority of us. But I think we also need to actually think about not only reinforcing the vitamin D intake, but looking at adequate calcium and healthy exercise and lifestyles. We need to use various tools that are well established, such as Canada's Food Guide. For those in the audience who are in the 51 or older age group, if you're drinking 3 glasses of milk or substitutes such as soy beverage or anything that's fortified, that you're not only getting your 900 milligrams of calcium that you need as part of your Institute of Medicine recommendation, but you're getting 300 international units of vitamin D. If you're the younger group, 2 glasses of milk will give you 600 milligrams of calcium and 200 international units, and you're doing pretty well there too. There are additional websites and other tools that have been developed, such as Health Canada and their website that I've previously shown you. Osteoporosis Canada has moved away a little bit from its original message of saying this is your concentration to actually what they put out on their website is saying that healthy individuals between the age of 19 to 50 years of age, including pregnant women and lactating women, need between 400 and 1,000 international units per day. For those who are older, who are at risk, 800 to 2,000 international units per day is actually adequate. Choosing Wisely Canada is a campaign to help us, physicians, and patients understand about healthcare. Its role is for us to be efficient, and there should be some cost containment at the same time too. That there are various tools that have been rolled out across Canada from various groups, including endocrinology this past year. And we're looking in terms of actually saying, well, what information can we provide to our patients? So Choosing Wisely Canada says, a test does not improve treatment. Few people have seriously low concentrations of vitamin D, which I think I've demonstrated with the CHMS data. Most of us don't need a vitamin D test, but we just need to make some simple changes. Who should have a vitamin D test? And this was a consortium of experts from the Canadian Association of Pathology, the family physicians, as well as the CMA putting this out, as well as there was input from a large other group of endocrinologists and other specialists. So if you have osteoporosis, you may need to have a vitamin D test. If you are unable to make or metabolize vitamin D, you've got some malabsorption problems, you may well need to have a 25-hydroxy vitamin D test actually done. So the recommendations are, if I just put out who should we test, those with osteoporosis, think about it, but certainly recommend, these safe recommendations, malabsorptive syndromes, hepatic or renal disorders. If you're worried that somebody has osteomalacia at your age group, so they've got diffuse aches and pains, my age groups, they've got nice bowed legs, which they shouldn't have. Older anticonvulsants will speed up the metabolism of 25-hydroxy vitamin D, and you may consider actually looking at whether that person is at risk, particularly if they have some of these other issues going on. If you have somebody with abnormal calcium status, or again, my age group that I usually see children with problems such as osteogenesis imperfecta, but they're going to be migrating up into your age category too. How frequently should we test? Well, knowing that 25-hydroxy vitamin D has a half-life of anywhere from 15 to 21 days, if it takes 5 days to reach 5 half-lives to reach a steady plateau, we're really looking at no more frequently than every 3 to 4 months. And in fact, the province of Alberta has said that no one can check a 25-hydroxy vitamin D more frequently than every 4 months. So we hope to say goodbye to those people who are doing 10 tests a year. I think also you need to look at your individual patients and decide which 25-hydroxy vitamin D target that you need, that you think would be important for them. It is important to realize that we have an excellent gold standard technique here at the Health Sciences Center and throughout Manitoba, because all of the tests are done here, with the exception of those under a year of age who go to the Mayo Clinic. So, in summary, I think that we all need to take a sufficient intake of calcium and vitamin D, that the status is good across Canada. Adherence to supplements, if they're needed, or a good healthy diet needs to be reinforced. We know that there are certain populations at risk, and having come here from Manitoba, I certainly see that on a regular basis. And I think that we need to work on our messaging. We need simple messages, and I think that you've already got our summary point right now in terms of there are individuals that may need to be tested, but generally not a lot of people need to do that. And I think that the message needs to be simple, fun, and clear. So I'm going to call upon Arnold here, and he just says, just take it, don't test it. And I'd like to thank you very much for your attention. If you have any questions, we'd be delighted to answer them. I'm supposed to ask if there are questions from the outlying centers first, please.
I've got a question from St. Boniface. Is there any synthetic light source that will increase the vitamin D in your body, or will only natural light do that?
I'm going to answer that. It's Celia. In fact, for children with cholestasis, we'll often use tanning lights. They're relatively expensive, but you can actually use cutaneous synthesis in children that have malabsorption. So yes.
And I will add to that there are studies that have shown that people that tan on a regular basis do attain higher levels of serum vitamin D as well, just by the fact that they're using UVB light, and which is the most important aspect of light.
Yeah, great talk. Is there any plans of limiting the testing in Manitoba, or what's the DSM's plan?
We are looking at all our options. There isn't any decision made, but we are looking at our options right now with the help of clinical colleagues as well. And we hope to have some measure of an understanding of where to proceed in the coming weeks or months, so to speak.
Well, what is the approximate cost per test? And I think that we should know that. And secondly, is there any evidence that the rise and fall of vitamin D has any effect on, again, the same thing that you've told us applies to whether we should have a constant level around the year?
I'll attempt to answer part of that question, and Dr. Rod here might interject as well. I would go back and say each individual is different based on their risk factors and the serum levels that they start with, as well as the amount of diet they're exposed with respect to calcium and vitamin D. I won't say much about that, but leave Dr. Rod to interject on that and complete that. But with respect to testing costs, that is very difficult to pinpoint because it depends on each assay. And I've looked at it, and I don't have an exact number for the assay that we do here right now, which is liquid chromatography mass spectrometry. But the cost of the assay is based on not only the test itself, but it's also based on the redundancy, the allocation of resources, for example. So my understanding is with the mass spectrometry assay that we do right now, I would estimate it to be around $27 a test. But what I would encourage you to look at it is how much resources is being allocated to that particular test that could better benefit testing on other tests which would benefit patients in other centers. In most cases, it's not only the cost of the test, but it's also the resource allocation and the time that it takes to be able to process a test, which would be better served in other high priority testing.
With regards to the question in terms of fluctuations in your 25-hydroxyvitamin D concentrations, we know that they fluctuate routinely in most individuals. The peak in the summertime, particularly around September, October, when you've been able to accumulate all of that vitamin D and transform to 25-OHD, and then the nadir down in the springtime. And of the various observational studies, not a lot of them comment on it. I can comment on one of the studies I did with healthy breastfed babies, and there was no difference in terms of the fluctuations that we saw on a seasonal basis in terms of attaining a healthy bone outcome. We compared different doses of vitamin D, but I think that once you're really above 30 nanomolars measured by an excellent assay, as long as you fluctuate above that 30 nanomolar mark, there's not a big issue. Important to know that once you do replete your 25-hydroxyvitamin D concentration, if it ever dips quite low, there's actually quite rapid remineralization. So as long as there's a bit of this fluctuation and that you're not going too low for prolonged periods of time, there's often a good recuperation. But certainly of the children that I see with rickets, it's often in February or March they come in either seizing or they have their bowed legs because that's their nadir.
I may have missed this. Did you say anything about giving calcium concurrently with vitamin D? Or is it possible that if you take vitamin D by itself, our diet provides enough calcium that we will be in good calcium state?
So the vitamin D and calcium do not need to be taken concurrently, as long as it's in your diet. And I do actually have a slide in terms of what the Canadian diet is. It's actually fairly poor. This is going back... There you go. It's this side here. So this was actually a study back in 2000. But when we actually look at dairy product portions, you can see adolescent boys do very well, as do adolescent girls. Older women typically are the ones, so adolescent girls and adolescent women and older women over the 50s and 60s mark typically don't get enough dietary calcium. So the whole question of supplements, I'm not talking about that because I know there's a whole issue about that, but really meeting the Institute of Medicine recommendations and Health Canada recommendations, you're fine. But often in the diet, adolescent boys do fine, adult men do reasonably well, but it's the adolescent girls and the older women who don't generally do well. But they don't have to be taken concurrently for it to work.
I'm surprised at the low cost you have for your assay. I was estimating at close to $100 an assay. Do you take into account the depreciation and maintenance of the equipment, which is a huge cost for a mass spec because they break down every time you blink?
Yes, all that is factored into the cost of the assay, including the labor as well.
Wow.
And
that's
the service
better
cost.
than almost anybody else I've heard. The other question I have is that we know when we teach that the older anticonvulsant drugs increase the clearance, which impacts on the level of vitamin D. And as we do with drugs like digoxin, where the absorption and distribution rate, in fact, affect the level you're going to see, is there any guidance for sampling that it shouldn't be in around the time of a meal, or any recording of concurrent drugs to see what other drugs might be impacting your levels?
No, in the laboratory we do not. We leave that to the discretion of the ordering physician to understand what medications their patients are on and to report, to review the report with that in mind and to interpret with that in mind. We are not privy to the information of what medications the patients are on, and we do not guide them on to when they should be sampling it, simply for the fact that we know unless your patient is at a high risk, we do not generally encourage population screening. So if the patient is on any anticonvulsants, particularly the older generations, then it's up to the physician to interpret that and make sure that they are looking at the results.
20 to 30% of Canadians will have fatty infiltration of their liver, and that number is increasing year by year. And if you're advocating that serum testing only be done in patients with liver disease and kidney disease, that's a large segment of the Canadian population. So there must be some criteria of patients with liver disease where vitamin D testing is actually required. What's the extent of the liver disease before you identify a patient as someone who should be tested for their level?
I will answer some of it and then I'll let Dr. Rod comment on it. Again, this goes back to the studies. There aren't any studies that conclusively define what is the appropriate dosage or the appropriate timing and what stage of liver disease, of infiltrative fatty liver disease, that these kind of tests are recommended. These recommendations that we present are mostly based on the fact that, yes, in individuals that have liver disease would have compromised hydroxylation of the 25 of the cholecalciferol to 25 25 dihydroxycholecalciferol, And because of that impaired synthesis, then it makes sense to be able to monitor these patients or test patients with that. However, there aren't studies that we are aware of that conclusively look at relationship of vitamin D status with liver stage disease.
Thanks. I did want to comment that the CYP2R1 that's important for the 25-hydroxylation is actually a very robust enzyme. And what I had always learned in my training, which I understand from Glenville Jones, one of my colleagues that I work with, is that you need practically a dead liver before you can no longer CYP2R1 or make that 25-hydroxyvitamin D. So I think it's a very broad statement when they're talking about chronic liver disease, and I think it's a very good point in terms of how do you what are the studies, but I anticipate that it's really only the individuals with very sick livers that will be an issue. It does raise the question, though, about obesity in general, and something that we didn't mention is that do we, with a larger population, with a population of large individuals, do we have different intakes that are required? Because we know that vitamin D is actually taken into the body and then deposited and sequestered in the adipocytes. But in fact, the Institute of Medicine said that these that reference intakes of 400 to 600 international units are perfectly acceptable recommended intakes for those who are overweight as well, too. And there doesn't seem to be any toxicity as people lose weight. It's a very gradual release of that vitamin D.
Any questions from St. Boniface? Manitoba Telehealth line? Okay, we thank you for your attention.